All right. Okay. I think we can get started. Welcome everyone to the University of Alberta Child and Adolescent Psychiatry Grand Rounds. I'm Dr. Alice Liang, and I will be your moderator. We're very grateful to be partnered with the Faculty of Medicine and Dentistry, Office of Lifelong Learning, and also the Physician Learning Program. And I'll introduce our speaker in a bit after we do our territorial acknowledgement here. So the University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Nehiyyo or Cree, Niitsi Tape or Blackfoot, Métis, Nakota, or Stoney, Dene, Haudenosaunee, or Iroquois, and the Anishinaabe, or Ojibwe Saulteaux lands that are now known as part of Treaties 6, 7, and 8 and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. So just a reminder to use the chat feature if you have a question about the logistics of the rounds. Otherwise, please put your question into the Q&A feature of the webinar. We will have live Q&A towards the end of Dr. Chang's presentations. So I will introduce Dr. Sam Chang, who is both an esteemed and I think fairly close colleague of mine. So Dr. Sam Chang is a board-certified child and adolescent psychiatrist. He completed his MD and general psychiatry residency at the University of Calgary, followed by an adolescent chemical dependency fellowship at the Mayo Clinic and a pediatric psychopharmacology fellowship at the University of Toronto. Dr. Chang is a clinical associate professor at the University of Calgary's Cummings School of Medicine. He also is a faculty member of the Reach Institute of New York, and he is the medical director of the Adolescent Addictions Program and admits to the inpatient young adult program, both of which are located at the Foothills Medical Center in Calgary. He does numerous clinical trials and continues to see new consultations in his office. He is a member of the Executive Advisory Board of Caddra, aka Canadian ADHD Resource Alliance. He is also the past board member of the Canadian Academy of Child and Adolescent Psychiatry and past president of the section of Child and Adolescent Psychiatry with the Alberta Medical Association. He is especially proud of being made honorary medicine man. So a warm welcome to you, Sam.
Thank you very much, Alice. That was a very nice introduction. And I understand as well that I'm actually starting off your this year's rounds program. So thank you for that honor. And it's interesting because what we're going to talk about today, I think, will fit in really well because although I'm going to talk about this specific program and content, so you'll see what I've been doing in the last year and a half of my life. This is my hobby here. But also, I think that it's a new way of doing CMEs that I think is really going to be happening in Canada especially. And we have to support both, you'll see later, both of the College of Physicians and Surgeons as well as Health Canada. So I hope to get in on at the beginning so you know how this works, but also I'm going to talk a bit about the content to illustrate the process as well. And I'll take questions at the end, either on the content or on the process. Okay, and this is my disclosures. You'll see, I do a bit of work with the pharma companies, but what's important in this case is I actually am not going to be talking about medicines. at all in this presentation. And also, this program that I'm going to talk about has been funded by Health Canada. And so everything you see, so the discussions here are funded. In these days, Robert Kennedy Jr., I'm always worried about that. I think Health Canada is pretty neutral and science-based and evidence-based and not empirically based and not like Robert F. Kennedy Jr. So I think I like to think that our what we've done is pretty evidence-based. Okay. So this is what I'm hoping to do is number one, telling you what this program is and the contents and how we got here. But secondly, we're gonna call this, and you can tell it's not like a fancy. I wish I had a more fancy name with an acronym. We call it the Integrated Knowledge Translation Model, and how we got to here and also around like what happens and what we're hoping to do, what Health Canada is hoping to do when they gave us funding. It's really to look at ADHD and substance use together because we know that this is a very, very common problem and with lots of worries. There are lots of concerns, but interestingly, when we reviewed all the data, there's actually really good data and really good consensus internationally on what we have to do. It's a little bit different than what I think most people are doing, but I think it's important that we know that there's really good data for this. So this is just an introduction to say, listen, substance abuse can be on a spectrum, right? You don't use, sometimes you have something where it's helpful for you, and it can go right to going too far where it becomes a use disorder. And what that means, of course, is that you have functional impairment, and that people can come back and forth between these over time. At the same time, there's a lot of substance use in ADHD. And you'll see there that about 25% of people with ADHD also have a substance use disorder. And if you actually look at what they use, you look on the bottom, about half of them use cannabis, the ones that use, about a quarter use alcohol, and about 20% uses cocaine. And then the rest is, the smattering or low numbers. But those are the ones that, and these ones are the ones that causes a lot of worries and concerns about what to do. And so it's important that we know a couple things. Number one, that we recognize it. Number two, we know how to assess them. And number three, we know how to treat them. And that's really the goal of this project, or at least the content of this project. And first, I'll talk a little bit about Caddra, in case you don't know. Caddra is a group of healthcare professionals, mostly doctors, actually mostly child psychiatrists, and our focus is on ADHD, disseminating knowledge and helping to for primary care and other people to treat ADHD as well as possible. It's also the source of our Canadian guidelines. So, if you look at the website, which is on the bottom, you'll see the guidelines if you're interested in that. And so what we did was we were able to raise some funds from Health Canada to look at this critical CME gap around ADHD and substance use disorders. That's what SUD means, substance use disorders. And these are what we had to promise to Health Canada in order to get this. And this aligned, of course, a lot of what Health Canada thought would be able to change some of the difficulties in learning how to treat this group, especially given our opioid crisis and substance use crisis in our country. So to start with, it's online. So you can actually, and it's asynchronous. What that means is that, you can log on, do your thing, and at your own time, you can break and come back. So it's really, really useful for everybody everywhere. It can be at different levels from start, for beginner to expert levels. And there's actually downloadable practice supporting tools that you can use. So we're not just giving knowledge, we're also giving tools. We're also teaching you what to do. and we'll talk about that a little bit later on. The goal is not only knowledge, but skills and confidence as well. And this particular project, we're looking at all healthcare practitioners. Primarily, we're looking at family docs and psychiatrists, obviously, but we also want to look at people that treat substance abuse. So, for example, addictions counselors, people like that, as well as mental health workers in the community. And then finally, Health Canada felt that it was really, really important. I think this is the big difference, that there was a lived experience led course. So in other words, of course we want data. We're going to have that. Of course we want expert consensus and data and meta-analyses, etc. But we also need to add that to our patients' needs because they really felt that there were, and we know that there's a lot of stigma to this, especially the substance use portion. And it reflects, and I've learned so much from doing this. It's amazing about how we're doing things, maybe not in the best way. We have the best of intentions, but we're not doing the best way possible. And of course, we also know from the literature is that one-shot deals won't do it. You might learn something, but if you want practice change, that doesn't happen with one shot. The best way to do that is to have what we call a community of practice, where you can talk to people, where you can have ideas back and forth, because we want to know to get comfortable, to build confidence. We need to know, well, how are other people doing it and how's it working? So we don't necessarily, it's just like a residency program. We listen to what our preceptors tell us. They're teaching us stuff, but we're also having to learn from experience, and we're seeing the other residents and what they're doing. And that's how we learn and build our skills and confidence. So that's what we want to do. And we were able to do with this project, which is why I think it's going to be the future for how we do CMEs. So this is the content, right? So CASUP stands for Caddra. What is it? I'm just blanking up. I can tell in the middle of a presentation. Caddra ADHD and substance use program, and so this is the content. If you look on the right side there, we want to understand the physiological connections. And there's a lot of data on why ADHD patients have more substance use. And so we want to understand that. And then once you understand that, then you can look at, well, if we know that this is very common together and we know the reason why, how do we assess? How do we diagnose? And then, of course, the next two things are management, medication management, psychosocial management. And if you look on the right side, this is what I mean by we have incredible support from the Royal College. We're looking at getting 11 3/4 Section 3 credits, right? Which means that you multiply that by 3 and you get 35.25. And for family docs, they get 35 Main Pro Plus credits. So you know how difficult it is to get Category 3 credits. You get Category 3 credits from taking this course. So that's around evaluating your own practice, right? So those of you need some Category 3 credits, quick way of doing it. And again, first of its kind. I think we're the trial for doing this, and the goal, of course, besides the ADHD and substance use, is to pilot this new way of doing things to see if we could get better outcomes from our CME time and dollars. Okay, so what we do is also it's also important with how we do it, because really getting information together and disseminating it, a lot of it depends on how we put that together. So this is what we did. We did your usual research evidence, and we did 10 years. And let me tell you, there was a lot of stuff in the last 10 years. I think it's over 300 papers. I can't remember exactly how many. That's why it took so long. I was the chair of the expert committee, so we looked at a lot of data. And then we also had healthcare professionals. We're talking family docs, psychiatrists. We're talking addictions counselors, mental health workers, as to see what they feel that they need because of, this is a population that everybody sees, I'm sure. And then here's the other one that we had 200 people with lived experience that we also had, and I'll show you how they fit into all this, that gave us their experience of what their needs are, what they need from their doctors. And boy, what like I said, I learned so much from these people. It's amazing. And I really realized just how, we have all these ideas of what people need. It's totally different than real life. So it was really great to have that. Here's some of the key features of that. We also believe that we don't want to just give you a bunch of slides, and you'll see some of that today. We want to have more ways of learning to be interactive, so you learn and it's not boring, right? I mean, we work with ADHD patients. In order for them to learn things, we have to make sure it's not boring. So we have some videos. We have some expert videos. This is more targeting family docs. We have some quotes from healthcare professionals as well as individuals with lived experience. So you see, and that's really impactful. You see some of that. We have interactive case studies that actually go through. We have several types of cases that are the common ones, and it goes through all four of those areas like physiology, assessment and diagnosis, and treatment. So we use that longitudinally. And I think this is part of how we got that experiential credit, because you have to put in what to do and how you would do it, and we give you feedback, and then we continue to follow through. So I think it's really quite good to look at actually what you actually would do. And then, of course, reflective tools and practitioner and patient resources. We wanted to make sure that we have resources that people could hand out to patients and that they could use themselves. And these are some of the examples of that. And of course, the community of practice, which we're really working on to make sure that we consolidate learning, build skills, build confidence. Okay. So this is what the model really has. First of all, and the top one, it's got to be evidence-based, right? We did a systemic review of high-level research. We try to go for any meta-analyses or high-level type of reviews like that, the latest data that we have in the past 10 years. As well, the expert committee would have perhaps some other studies that may be very fundamental to these other levels of research that we included in this evidence review. Then we put all the information together, both from the expert as well as the healthcare providers and individuals who lived experience. And we have various committees that I'll talk about a little bit more later on. And then we develop some content with different formats so that it's not boring. And then we send it back out for review. So there's, review the content, we review how it's done. And Health Canada, we also want to make sure that that diversity, equity, inclusion needs were looked at. We felt that that was very important, and the advisory committee reviewed that. I actually, even though I'm not on that committee, I attended one of the committee's meetings where they had somebody. It was actually a PhD psychologist from the East Coast that has a problem with opioid dependency herself. And boy, oh boy, did I learn an awful lot from somebody who was very, very credible. And then we did beta testing from healthcare practitioners, got their feedback. So you can tell, like I said, this was my hobby and it consumed 1.5 years of my life. I still think we have a little bit left to do. Okay, so here's an example of the how we work with healthcare professionals. We did a needs assessment with healthcare professionals. We had the advisory and expert committees that looked at these needs. And then we created the content with the committee's expertise. So this is very typical of your usual CME, right? You've seen that. And then we tested with primary care practitioners. So we did what we usually do with any CME program. And here's an example of trying to engage with healthcare practitioners. so that, but in kind of a way that was engaging. And I'll show you this. It's a video between Dr. Willems and myself on a little bit of this. Before I start this, I just want to I have to thank the people that were involved. Dr. Willems was one of our international consultants, and he was so excited about what we did. He not only did he want to consult with us, he wanted to be involved. And those of you that might know him, Tim is the director of the pediatric psychopharmacology clinic at Harvard. So here we are.
I think we have to have heightened surveillance around that, not paranoia, but heightened surveillance. And in doing so, I think we take really good care of our patients, and it's not a lot of extra work for anybody.
Yeah, and it's always that risk versus benefit, and I think overall the risk is far below the benefits of the psychostimulants.
Okay, so we've done again, and so that's kind of the talking with experts around what they're seeing. And then here's another one, and you might know your very own Dr. Ahmed from Edmonton. He's on the Caddra board and one of our expert committee people, talking about what happens in primary care. Here we go.
Of course, this is the joy, especially in primary care, where I can see the patient, and hopefully the patient in the context of their community and their family, is to see what their external variables may be playing a role. If there's any relationship stress, financial stress, work stress, school stress, whatever. And having the ability to follow up with them multiple times really can be very helpful to get a better idea of what's going on.
All right. And so this is some examples of that, and also healthcare practitioners. So we use videos. We also use quotes. And I'm sorry, I don't know why it kind of came out a bit fuzzy. I'll read this out in case it came out fuzzy on the other end too. It says from Jermaine, a healthcare professional, we need to reduce the stigma of treating ADHD while patients are in the pre-contemplative or contemplative phase of active addiction or early recovery. Otherwise, it's the equivalent of telling someone on fire that you won't help until they stop burning. So we thought that there was a really good quote from people that have been working with this group of people, but didn't know what to do or how to do it. And except that they know that what we've been doing doesn't work very well. So I think it really shows the impact of of some of this on healthcare practitioners besides the patients themselves. And here are some of the examples of the practitioner resource. This is part of the reason why you get Category 3 credits. So you actually have a self-assessment checklist, right? Where you can ask questions around how you approach it, how you do it, and how you do it in a non-judgmental and compassionate manner. And actually, we actually use a lot of quotes, actually not quotes, scripts. Because, it's easy to say everybody believes, like, do you have to be non-judgmental and compassionate? Of course you have to be but how do you do it? So I know that we have different videos in there of a clinician being non-judgmental and compassionate, and also using the language that individuals who lived experiences would find as being non-judgmental and compassionate. So you might think you're non-judgmental and compassionate, but does the patients feel you're being that way? And I think that's really important too. And then reflecting on, what you know, and we do this at various times, right? Like you'll go through the course, then we have some information, and then we go back as well to see if you learn what you learned. And actually, we're not seeing it; you're seeing if you learn what you've learned. And you'll see there your answer is not saved online. So we don't want to make anybody feel bad. We just want to make sure that you know what you've learned and you know what you haven't learned, so you make sure you get that. Yeah, we're not keeping track of anybody. We're not giving out scores and comparing to anybody else but you. Okay. And here's an example of a community of practice. And this we tried this out pretty early to see how it works. And it's, how do you, so this is an example of our attempt at doing that, but doing it online. Because obviously it's pretty hard to have a discussion forum with people that are, in person. especially across the country since it's a Health Canada endeavor. So you have to be able to do it and in 2 different languages. So we have it in French and English, by the way. So if you're a francophone, feel free to do that as well. So I think this is really a really good innovation as well. Besides how we put the project together, is the fact that we also want to maintain you in a community of practice after the CME is done in order to consolidate learning and build skills and confidence. Okay, so that's how we did it with the with doctors and therapists. What we did with the individuals with lived experience, we did the same thing as well. We had a needs assessment in terms of what they see, and then the group that worked with them was the advisory committee. That was the group that I joined, that I listened to what they were learning, and said they had experts from the community of individuals with lived experience to talk about what they've experienced, why they've experienced that, what their needs are, etc. And then we also had extensive interviews with individuals with lived experience, and we actually have them look at, this is what we're going to suggest that people do, and how do you feel about it? So again, they get a chance to feedback. So we're not just getting information from them, we're getting information back to them for them to review to make sure that we're going to meet their needs too. We're interested in meeting the needs of our patients, not just of the doctors. And I think this, to me, is the key in this integrated knowledge translational model. So that translation is really the key. Not only do you have the knowledge, we have to translate it in such a way that patients find non-judgmental and patients find that are supportive and useful. Okay. So here, of course, these stories are so good that we didn't want to just keep it to the advisory committee. So we've actually put it out in the course. So this is another case of Kate, who's actually an individual lived experience, and here you'll be able to hear what she has to say. I think this is actually quite impactful.
No ADHD diagnosis. I self-medicated in my 20s with alcohol. It was hard to have a job and concentrate, and it was impossible to stop self-medicating when I had no other treatment options. At the time, I had no understanding of why I was different. I know now I had undiagnosed and untreated ADHD.
Okay. So again, we get some learners get to learn about the experience that people has an impact on them. And here's an example of the case study that would follow through. And this is a case of somebody that had early onset substance abuse. So you see the case there. I won't repeat that. She uses the opioids a lot, and then you get cued of what you would ask, and essentially what happens is you find out that she's been using, and you notice it says unregulated opioids. Our individual lived experience says when you say street drugs, it makes it sound dirty and illegal. So unregulated opioids or unregulated stimulants, that's the kind of thing that would be helpful for them. That they would find if a physician spoke with them that way, they don't feel judged by them. Because remember, they have a tough time even coming to see you to start with. If you ask them about this, it happens, and we teach you how to do it, of course, including with scripts that you can ask. But you find out that as far as the content goes, she's been using since she was 11 years old, and she would have intermittent times, and she wouldn't, be used much less, and other times when she'd be using a lot of times, and when she stopped, times when she'd go back to using. And then you also had symptoms that would indicate ADHD that's going on right now. And of course, if you were to ask her, well, can you tell what you were like before age 11? Did you have those ADHD? She doesn't know, because it goes back so far that she doesn't know. And you might think, well, age 11, isn't that a bit early? The answer I have for you is no. The age where kids begin to use, when they begin to have risk of substance use, is whenever your age reached double digits. So that means age 10. So this is a big problem, and that's why often they get missed because we think, oh, a 10-year-old, that's like in grade 4, they're not going to be using. Well, surprise, surprise, they are. And so, any type of those of you that are working with prevention programs, you got to get in there by age 9 because, if you wait until they're later on in elementary school or junior high, when I remember we had some people talk about drug use, the horse has already left the barn. So you got to start really early to make a difference. Okay. So we also have patients as well that ask us, well, what do I need to have an assessment? And also doctors or other people, well, if you want me to have an assessment, well, what's going to happen? This is just some of the tools that we can use. You can use a checklist and it continues on down. It's not the only thing that's left. But what it does is it shows people, demystifies it. What do you mean by an assessment? What do you have to do? So it demystifies it, especially for our patients, but also for doctors as well. And all of this basically is to make sure that we meet DSM-5 criteria, right? Some things you don't need, some things you do need. And I put down there, not only do we have resources for patients, resources for healthcare practitioners, we actually teach healthcare practitioners what to say when patients say this. Because obviously we know from the 200 individual lived experiences, they ask all kinds of questions. What are the common questions? And how do you answer that in a non-judgmental way that they feel supported with? So we actually, not that you have to use our quote, but at least it's a start so you can see what we mean when you can, of how you would express these to them. And of course, these were reviewed by individuals with lived experience before we go back to teach, the docs and healthcare practitioners. Okay, so that's the process of how we get there. I think it's really quite, like I said, I think this is the way we're going to do things later over time. From now, this is the first project, and I think we've had some really good outcomes. We're gathering data right now. And hopefully we'll have the outcomes of that coming up, and and we'll have more evidence over time. So, but I'm getting this to you kind of at a time when we've just got started, and so here's the key. If you want to know, well, what's the content? Like, what did you guys actually find from all that meta-analysis and your chart reviewed? Number one is that if you're looking at ADHD or if somebody has substance use, then you got to think about them both at the same time. Don't think of one without the other. And remember, even down to age 10, you want to think about both. All right. Remember that patient, that our mock patient, actually started at age 11. So very early. Make sure that you treat them. Don't think, oh, I'm just treating little kids. Well, little kids are using drugs. If you don't treat ADHD, don't think that you're doing anybody a favor, because if the symptoms are there, patients are going to want to self-medicate and treat themselves. And of course, treating themselves, I always say, when you self-medicate with unregulated substances, the problem with that is that you can get high. And the reason is when you get high, anything that you can get high with, you can develop gradual tolerance. So it works for a while, but pretty soon you're going to need more and more and more in order to do the same thing. And what happens when you use more and more of everything? Well, you get more side effects. And what's the side effects of using unregulated substances? Is that whatever you're using to self-medicate, whether it's anxiety, whether it's depression, whether it's attentional problems or that impulsivity or the anger, what happens is that gets worse. It doesn't get better, it gets worse. So you have to use more and more and more, and pretty soon it doesn't work at all. So that's why self-medication is not an option. Okay. Again, that's one of the scripts that we tell people. Feel free to use it if you want, but that's what we say. And then concurrent treatment is the best practice. Actually, from the data, it shows that if you have ADHD and you treat that well, even if there's substance use, the chances of them getting free of substance use is going to be much, much improved if their ADHD is treated. If their ADHD is not well treated, they're going to have a tough time stopping, right? So whatever other things that are going on, treat that and treat it at the same time as you're treating the substance use disorder. And the other now, the other thing that we found was that ADHD medications does not increase substance use risk, and actually, that's being very, very conservative. In a lot of papers that we found, it decreased substance use risk. And so, especially in kids, and you know now that age 10, so if you have that young child in your office and they're just starting school, they have ADHD, don't say, well, let's wait to see what happens. Because if you wait to see what happens, they're going to get into the age where they're going to risk substance abuse use, and then you're going to have real problems. Treat them right away. That decreases the use. It does not increase the use, or increase risk of use. And the only the only other piece is sometimes we obviously have lots of high level use. And that's the case, then really it's no different than any other psychiatric concurrent disorders. You treat the one first that is at the highest functional impairment. So if you have somebody who's depressed and suicidal and have ADHD, you're going to treat the depression and suicidality first and then deal with the ADHD. But if you have a plain old depression that's not at risk, you're going to treat them both. And you need to treat them both. The same sort of thing with substance use. But I'll entertain any questions a little later on if you have some specific examples. It's really hard to talk about the hard and fast, which is why we use examples. We have cases to review. And then I did not realize this, that individuals who lived experiences face a lot of stigma getting ADHD diagnosis and treatment. So for example, we have people that have, they were a substance user 10 years ago, and they come to a doctor and they realize that they have ADHD, they want ADHD assessment, and the doctor will say, oh no, you've been in and you had problems with drug use before. We're not going to be treating ADHD. You're not going to be treated because that's not a good idea to treat you because the medication could activate your substance use. No, it's not. Please treat them. That allows them to do better, function better, and actually improves their ability to stay away from substance use. Just so that you see how important this is, there's even data that people with comorbid ADHD and bipolar disorder, if you treat ADHD while their bipolar is also treated, there will be less manic episodes. So again, it's not different than any other psychiatric disorder. You treat what there is and you treat it well, and that helps our patients to stay well much better. And that includes ADHD and substance use. It's no different than anything else. So as far as this project, we think we feel the importance of this is that we're able to combine our usual empirical research data, but also add the healthcare practitioners' needs and our patients' needs as well, the intended patient groups' needs. And we have a CME that comes out with just a very, very strong evidence, no different than any other CME that was done based on evidence, but we're able to integrate knowledge, skills, and confidence all at the same time and make sure that we're meeting our patients' needs. It addresses a huge gap. We're not only providing knowledge, but again, skills and confidence, and that's why that's so important. And we're hoping that what we're calling an integrated knowledge translational model will serve as a CME model for the future. And certainly that's what Health Canada is hoping for. And that's also what the college is hoping for. So you might see more of this. And of course, you benefit because you're going to get Category 3 credits, but just by signing on to an internet course that you can take anytime. Right? So good heavens. So again, just to show you, reminding you that there's lots of credits, tons of credits for it. And if you look at cost per credit, it is very, very low. If you're a Caddra member, obviously non-Caddra members a little bit higher. And we did this because we really want you to be a Caddra member. That helps as well with the community of practice. Because if you're a Caddra member, you get all kinds of updates. You get all kinds of emails. You can be involved. Some of you might have been in a fireside chat with experts. And of course, you have our annual general meeting, which this year is in mid-October in Vancouver. So come and join us. And I've also put in some of the other costs for other people as well, because we have a lot of interest in this internationally. So you're getting a really good deal. And if you're a member, then it also helps your practice in the long run. So I hope I convinced you that this new way of providing CMEs works. It's going to be it certainly helps our patients, helps yourself to do a better job, and of course helps you to get really great credit hours for cheap without a lot of money. And I'm going to end here. This is how you get to us. You go on the Caddra website, right? Caddra.ca, and you click that ADHD Learn, and you get in. And if you want to use QR code, there it is. I'm going to leave this up. This is the end of my talk, and I'll entertain any questions.
Thank you, Sam. So before we go to the Q&A, and I think there was, a question in the chat, and if people want to put it into the Q&A section, or we can have live Q&A, and you can talk to us if you raise your hand. But before we do that, just a reminder that these rounds are accredited by the Royal College of Physicians and Surgeons of Canada, and also the College of Family Physicians of Canada, and that we will be sending a CME certificate for live attendance. So Dr. Chang kindly has agreed to share his slides, and I think what you're talking about, Dr. Chang, is in addition to usefulness in and of itself for individuals who have, substance use and ADHD, it's very much in alignment with compassionate intervention in Alberta, and there actually will be a surge of employment opportunities for all of the beds and the follow-up that's required of compassionate intervention. Maybe what I'll do is there is one earlier question about what if the person is self-medicating with their ADHD medications in terms of abusing it?
Yeah, I'm seeing that. Yeah, thank you, Melissa. That's there's actually two answers to that. Number one, what if people are self-medicating with ADHD medications? The number one reason why adults get diagnosed with ADHD is that the children are diagnosed with ADHD. It's so common that when I talk to the parents, I say, well, can I get assessed for ADHD? The next question I ask is almost, so what was it like when you tried your child's medication? They might not have told me that, but I know that they tried it, right? Say, well, yeah, it worked really. And they kind of sheepishly tell me, well, yeah, I did try it once, but boy, did it ever work well, because they're just like me. So actually, that is not an impediment to treatment. The important thing is see if they meet the criteria for a diagnosis. And I tell them, well, look, that's not a good idea to do. The best thing to do is for you to get your own assessment and then have your own prescription to be treated. So we give the child enough medication for them that may not necessarily be suitable for you. And sometimes, even though your child, you think, well, they're on a small dose, it's actually a much bigger dose than you should be taking as an adult. So, because your metabolism slows down compared to a child. So get yourself assessed first before you do that. Abusing stimulants. So abusing their own medications is, I like that question. That question, it all depends, right? It depends what you mean by abusing, because there is, I think and I won't go into it all here. Again, there is the definition is very important. Words are very important, as you've learned from this. So words can hurt. So if you're saying you're abusing medication, there's a certain meaning to that versus what if you're misusing the medicine, right? And so so people may not necessarily be abusing, they may be misusing. Let me give you an example. You can have patients that say, look, I'm on medication, I'm on whatever stimulant, and it wasn't really working that well. So one day I took two of them. Or I've been taking a couple and lasted a while. And but boy, it seems to be working really well. But I've getting all the side effects. My heart beats faster and everything else. And I've tried it for a little bit, but I did it during exam times, and I really did well. But I'm not sure what I should do now. That's not abusing it, right? That's misusing it. There's a very big difference. So again, we really have to understand what the patients are. And so what we do here is when you hear that, then there should be a tool that you use, just like anything else. If somebody tells you, I'm feeling really tired, and I don't have really good, exercise tolerance. Like, what do you think might be going on? Well, right away in your mind, you're thinking, okay, you get a bunch of questions you ask, and then after that, you're going to do a lab test, like a CBC or a thyroid, right? Well, in psychiatry, we have our lab test too. It's called a rating scale. So we give you a rating scale. That's the downloadable stuff. You get a rating scale and you can use that. And you know what the beauty of a rating scale? It's non-judgmental. You're just using a rating scale and you're asking questions on a rating scale based on the patient's answers. So use your psychiatric lab test, so to speak. So again, this is what we hope to do to help people with cases like that. Okay.
Yeah, thanks. There's actually a chat here. Sorry, only Natasha can respond to the chat. I can only do verbally. I can't actually message.
Okay.
But Natasha, can you put up Dr. Chang's last slide so that they can access his link? So if you could do that, that would be
sure.
appreciated.
Dr. Chang, could you reshare your screen with your last slide there?
I've kept it there. Do you want me to kind of?
Yeah, they're asking if you can put up your last slide so that they can access your link for this CASUP course, presumably.
Yeah. I will do that right now. There you go. Can you guys see that now?
No, you'll have to share your screen.
Oh. I thought I should. Oh, okay. I think I know what happened. Okay. Let me see here. Sure. Oh, here we go. Yeah. Okay. How does that look?
That's great. Okay, thank you. So, Dr. Young, there's another question here. Is a question about challenges with psychologists making the diagnosis of ADHD. I guess, based on psychoed assessments on young children in the context of childhood trauma, poor sleeps, other stuff going on, and that, she thinks that doctors should be involved in the diagnosis of ADHD in these situations. So, any advice on how to approach this, and that these kids may also be concomitantly experimenting with substances.
Yeah. Well, that's a wonderful question, and it really starts, and that observation goes back a long ways with Michael. Is it Michael Rudder? And actually, no, it's actually before that. It's Stella and Chess, where they found that kids with difficult temperaments were a lot more likely to be abused. And what's a difficult temperament? These are kids that don't have really good schedules. They eat and sleep at all different times. They're kind of irritable, crying all the time. If they try to cuddle them, they don't like to be cuddled. They arch their backs and not cuddle. They're just difficult temperament kids. And if you think about it, difficult temperament kids are a lot more likely to have ADHD. So ADHD kids are more likely to be abused because of their ADHD, because they tend to be also from ADHD families, which have less likelihood of being able to cope with all of that, especially if the parents are untreated ADHD, etc. So you can just see all the family systemic dynamics. So I agree that it's very more common that there's going to be some sort of a trauma that's also going on when there's ADHD. However, it's also important to know the predictive value of diagnoses. So, number one, do you need to have neuropsychological assessment in order to diagnose ADHD? The answer is no. ADHD is a clinical diagnosis. So, what is the value of that? Well, the value is that if a psychologist diagnose ADHD from the psychological assessment, the positive predictive value is very, very good. It's upwards of 90, 95%. So in other words, if a psychologist says you have ADHD, you pretty much have ADHD. You can take that to the bank. However, the negative predictive value, which is if the psychologist says you don't have ADHD, what's the chance that you actually don't have ADHD? Well, the value is only 50%, like 0.5. So it's only 50%. It's like you can flip a coin. So I know a lot of times doctors are, they may be afraid to make the diagnosis and say, well, let's get a psychology test done. And the psychologist says, oh, they don't have ADHD. Well, that predictive value, the negative predictive value is only 50%, right? So it's helpful if they say they have it, but it's not very helpful if they say they don't have it. You still have to use your clinical acumen. So, yeah, that has a multifaceted. I hope I've answered those questions in a roundabout way. There's that trauma bit, ADHD, psychology versus, the clinical assessment.
Yeah. Did you want to comment on the use of the, TOVA and other, I mean, they're maybe not psychoeducational testing, but they're, I guess, an adjunct to diagnosis. For example, if the kid's not in school and maybe the parents aren't the most reliable historians, etc.
Yeah. So it's not, there's not one specific test that is going to be diagnostic of ADHD. I think that's part of the problem with some of these is that people say, well, there's going to be a specific test. What it really is that it's the overall picture. And that's why we had that, I think I have one as an example. What does an ADHD assessment entail? And you'll notice that what it entails is, you get to see somebody to talk about your history, to look at your symptoms. And of course, what we didn't have further down, it's, you have to look at your functioning. You also have to look at your, past history, how, that you've had those. So that's really the key. If you look at any sort of test or scan or whatever it is that we're doing, what they do is they'll say, once you've been diagnosed with ADHD, what's the likelihood if we did the MRI, if we did the, PET scan, SPECT scan, or if we did the, rating scales that they actually have that? So in other words, what's the gold standard is you making the diagnosis, right? So don't be afraid to make the diagnosis as a physician using your clinical skills, because if you look at the DSM, that's what it takes. Everything else, it's great to have. And if you're, it's great to use maybe to find out comorbidities, learning disabilities, everything else. But it doesn't necessarily, you don't necessarily need that to make the diagnosis.
Thanks for that. So I do have another question related to, what you said was the stigma of, treating ADHD while in the, pre-contemplative, phase, because I guess MI is part of that gold standard of, addressing, but do you have any other, tips in terms of, when, because I think sometimes in our business, we have so many patients, it's just easy. Oh, they're pre-contemplative, wait till they're more contemplative before they come back. And then, treat, but, and MI is good, but, is there any more that, that you would suggest?
Yeah, well, again, I think the best thing, first of all, please take the course, anybody, because we try to answer all of those things. However, I'm a child psychiatrist, right? So what I do is, let's say a child's told me that they're abusing drugs. And the first thing I try to do is, well, I'll do a lot of psychoeducation around that. And I think I've told you about some of what I would do. But then the next step I will always say, I think that's important that we kind of discuss this with your parents. Are you going to be okay with that? Now, a lot of times they might not be, of course, but other times they might be. But then I'll say, because I think it's because you know how when we started your ADHD treatment, I talked about the medicine and the side effects and good effects, and both you and your parents, were okay with that. Well, now when you're using other things, there could be interactions with things, and they could affect, what we treat you with or how much we use. So I think it would be really important for us. So I would say the same thing, much less, if they're, let's say they're using, energy drinks. I would want to discuss that with them and their parents. So don't think about drug use as any different. Because if you have that perception, oh my God, that's bad, that's going to come across in your tone and how you relate to your patients. Just think about it as, okay, so this is something else that they're doing with the medication. That's important for we can talk to your parents about it. And if you talk about that, and we teach you how to do it, by the way, how do you talk? How do you say? Again, we have scripts that teach you that. You can use that. You can use your own. Doesn't matter to us, but at least you have some idea of what to do. That's really the goal. So that's really the goal here is to show that substance use disorder and ADHD are no different than any other mental health disorders, and you approach it in the same way. A lot of it has to do with the language that we use, what we say, and if we, and if we, know what those triggers might be for our patients and do it in a little different way, you'll get better outcomes.
Thank you. Yeah, because we do work with kids, and most of them are attached to caregivers, that should be involved. And then, so there's another question from Tanya here. Dr. Chang, how do we screen or look for warning signs that the substance that is being used is screen time?
Oh, that's a really good one. I can do a talk about that. Yeah. And I have them. Well, I think the best thing to do is to start off by asking the young person. The parents often come up and say, "Oh, yeah, he's been using his screens all the time," and what I'll do is I'll say, "Oh, well, Johnny, how often, how much time do you think you're spending on the screen?" I don't know, 2 or 3 hours a night, four, something like that, and then you'll hear this from the parents. It's, "Oh, it sounds like you don't disagree, that you disagree." Right? Oh my God, the minute he gets home from school till he goes to bed, midnight, 1 o'clock, he's on the screen, right? And then I kind of make a joke about it. And I'll say, "Are you guys living in the same house?" you know? So I'll tell you what, why don't we check it out? I like for you guys to keep track of your use. And so what I like to do is, one of those calendars you can get from, I don't know, like the drugstore or something, we have those squares for each one. Each day, I'd like you, Johnny, to put down how many hours that you were on the screen in a blue pen. And then mom and dad, each day, I'd like you to put how many hours that you think he's been using with a red pen. And then I want you guys to come back in about a month and we'll see what we have. I want you to bring that calendar so I can see it, right? That's how I would start. That's no different than, if somebody, is telling you that they have something, you want to see how much there is, you want to quantify it, right? I'm feeling really like, when I'm exercising, I feel my heart beating in my chest, and I'm wondering if my heart's okay. Well, you're gonna do their vitals, check their heart rate, and do a blood pressure, right? You need to quantify things. That's what we do in psychiatry. We quantify as well. We're doctors. That's what we do. And so no different. Do the same things. A little bit different tools, right? But really, the concept is the same.
Okay, Dr. Chang, it looks like we're at the end of our time. Wow, thank you for this, enlightening and, sort of, rich tips and also great information about the CASUP process. So yeah, thank you very much.
Well, thank you very much for having me. Like I said, I think we're very excited about having this. And it's, if you're interested in getting lots of CME credits, especially the good kind, the tough time to get, it's not expensive. You can do it at your own time. But thank you very much for having me, for starting myself off with your grand round schedule this year, Alice.
We are honored to have you with us.
Thank you. Bye-bye, everybody.